Aloha. Welcome to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island, ER Doc on the Big Island, and working with the Hawaii IPA. We've had a series of conversations about healthcare reform in our state, the impact on the health insurers, most importantly, the impact on patients, and how it affects government here in Hawaii. Today I'm feeling very lucky to have a friend of mine, Dr. Kenny Fink, join me to talk about the impact of healthcare reform on his division, which is the MedQuest division here in Hawaii. Kenny's the administrator, he's a physician, went to Haverford College, University of Pennsylvania for medical school, has 2 master's degrees, one better than the next, master's in public health from Chapel Hill, and then master's in government administration. And he brings a fair amount of expertise on many levels, but he's really been a terrifically hard worker for the state of Hawaii, guiding the MedQuest division. So Kenny, welcome to my show.
Thank you for having me.
I really appreciate it. I don't think people understand what a gigantic piece of the healthcare system the MedQuest division is. So if we could start there, could you please, well first, tell us a little bit more about yourself. You've been involved in some big programs nationwide, right?
Sure.
Tell me a little bit about that.
So coming out of training, I was working at the federal government, the Department of Health and Human Services, at an organization called the Agency for Healthcare Research and Quality, where I directed a national program called the U.S. Preventive Services Task Force. So they recommend services on clinical prevention that are adopted and covered by multiple groups of insurances.
Okay.
So actually under the Affordable Care Act, which I think we'll talk about,
For sure.
it mandates coverage of services recommended by that group. So they've gotten some recognition.
So did you, so you're saying that some of the work that you did ultimately got incorporated into the Affordable Care Act?
Yes, that in the support of the U.S. Preventive Services Task Force, its recognition nationally, that it has become basically mandatory that their recommendations get covered.
And I'm glad you're mentioning this, because a lot of what our topics have done is they've come back around, as I've talked with some people like Beth Giesting, who we both work with at, I think Governor Abercrombie's administration, and Hilton Rathel and all these people, and how we've focused on the healthcare changes. The system is really meant to focus this Affordable Care Act on prevention, on primary care, changing the healthcare system in some ways very fundamentally. And I don't think people, maybe it's difficult for people to feel that, but you're expressing that that's a reality.
So the Affordable Care Act, I think, does a number of things. One of the first steps is to get people to have health insurance,
Right.
which is, as they would say, necessary but not sufficient.
Right.
Just because you have a health insurance doesn't mean you're having access to care or receiving high quality care.
Right.
Hawaii, with its long-standing history of the Prepaid Healthcare Act, and actually through its Medicaid program, which has been an expansion program, meaning it covered additional people, Hawaii's had one of the lowest uninsured rates in the nation.
Right.
So that really is a credit to Hawaii. So the impact of the Affordable Care Act from the insurance perspective wasn't a perfect fit for Hawaii because Hawaii had already been so innovative.
Right. Yeah, and now the work that you did, though, at the Preventative Care Task Force, though, those were the kind of foundational pieces that they, in Washington, D.C., were able to look to capitalize on, because some of those things obviously were relevant and very important to what we do here in Hawaii. I think we've spoken about the relatively low uninsured rate before. It was 9 or 10%, and I'm guessing that once we see the number settle out, it's going to be a couple points lower. But so much of what the Affordable Care Act is about is really about these prevention, pieces. But at the MedQuest division, why don't you break that out a little bit for people? Because I'm not sure people maybe even understand what Medicaid is. So start from the beginning.
Okay. The MedQuest division is the name for the state Medicaid agency.
Okay.
Medicaid is actually an optional program, but every state has chosen to have a Medicaid program. And Medicaid is a partnership between states and the federal government.
Right.
So for every dollar spent in a Medicaid program, the federal government will reimburse the state a certain amount of funds. So in Hawaii, it's roughly 52 cents on the dollar is federally funded. So anything that we want to do in the Medicaid program that touches federal funds, we have to get federal approval.
Okay.
So in the state, we want to make state policy and think it's a state program, but we always have to get federal approval.
Right.
So we kind of have 2 masters in the program.
Got it.
Medicaid exists primarily to serve low-income individuals and those with disabilities.
Okay.
So the program really was created for children and pregnant women and families. It was under the Affordable Care Act that it really expanded more to what we call the adults without children.
Okay.
But all of these folks need to be of low income.
How low, just so our viewers can kind of wrap their minds around it?
The federal poverty level for Hawaii is around $13,500 a year.
Wow.
So to be eligible in Hawaii for Medicaid, a child could be in a household that makes 3 times that amount.
So mom, dad, and the child.
So if it's a household of 4,
right,
they could make $76,000, and the children could still be eligible for our Medicaid program.
Okay.
For a pregnant woman, it might be closer to $20,000 a year that she'd be eligible. Mm-hmm. But for most other adults, it would be around the $13,000.
Okay.
Now, again, under the Affordable Care Act, that expansion
mm-hmm.
Brought it up closer to around $17,000. So if you're an adult, mm-hmm. without any children, your income is around $17,000, you might be eligible for Medicaid now.
And what does that get you? If you are basically poor, you're making not very much money, only $1,000 or $1,300 a month, something like that, what do you get?
So if you're eligible for Medicaid, we have a very comprehensive Medicaid program. Mm-hmm. So you get the full spectrum of covered services, from doctor's visits, hospital care, to prescription medications. Most medically necessary care would be covered, and it would be absolutely free.
Okay. Yeah, this is, when I go back on the weekends, I'm blind to it because I'm in the emergency department, but I know that has been one of the challenges that healthcare providers have brought up. In some parts of the state, it's very good and valuable that everyone has some form of coverage, but I've noticed and heard stories that in some parts of the state, some providers won't take Medicaid. What's that about?
Just one other thing about our coverage,
mm-hmm.
Medicaid is probably the largest financer of long-term care.
Okay.
So when we think that we provide health insurance for low-income individuals, the bulk of our expenditures is for long-term care. Okay. So that's an important point to understand when we talk about Medicaid program. We are largely a long-term care program as well.
Is this for individuals that no longer have assets but need somewhere to be as they're 70, 80 years old and need to be in the hospital?
Correct. So it's for individuals who need that level of care, and they have to meet both income and asset requirements. So that's correct.
Okay. And essentially, to take a step back, it's a safety net program in its purest form. If you're very poor, but you still obviously have health care needs, you have an asthma attack, you have an accident, mm-hmm. you have chronic illness like diabetes, you won't be left without access to care. What happens if you fall in that middle category? If you are an individual and you make $20,000 or $25,000, then what are your options?
Right. So I had read actually that healthcare costs were the leading cause of bankruptcy.
Right.
So one of the wonderful things about the Affordable Care Act is now that everybody should have some access to health care. So for people who make too much money to be eligible for Medicaid, they would be eligible for subsidized health care through the health insurance exchange.
Right.
So there now is an option for them.
Okay, right, and that was an important addition from the Affordable Care Act. And we don't get particularly partisan on this show, but I do recognize that some people have utilized that. We've talked at different times about whether the exchange has been successful or not, whether it was totally necessary or not. But one thing is clear, and that is it is another option for people to avail themselves of, and it's actually mandatory now. Is that right? If you're uninsured otherwise.
So there is a federal requirement that individuals have health insurance. There are certain exceptions, but largely there's a new individual mandate.
Okay, so we're moving towards getting everyone health insurance.
Yep.
Now let's go back again a step. So Medicaid, how many people are on it in our state?
Okay, so I started this job 6 years ago.
Right.
And when I started, the enrollment was 210,000.
Okay, and that's out of about, at the time, 1.3 million or so, yeah?
Probably less than that statewide.
Okay.
But we might say it was around 20% of the state population.
Okay.
When the Affordable Care Act became implemented in Hawaii in October of 2013, mm-hmm. Our enrollment was closer to 280,000.
Okay. Was it crazy legislators expanding the roles, or we were just being smart about things?
Well, I think we were coming out of the recession, and we saw a real increase in our enrollment.
Right.
And I think that was a large contributor for the increase.
Okay.
So between October 2013 through June 2014,
okay,
our enrollment had increased an additional 30,000.
Wow.
So in June, we were at 310,000.
Okay.
That was an 11% increase over October.
Wow.
So you might attribute that to the Affordable Care Act.
Right.
And it was almost 50% increase since when I began my job.
Wow. So you're a real social program wonk.
Something like that. So now we're serving closer to 1 in 4 Hawaii residents.
Wow. So 1 in 4 Hawaii residents, just so I make this very clear, are now eligible for Quest or Medicaid coverage, which will provide the full complement of healthcare insurance coverage.
Yes.
That's pretty amazing.
Yes.
And I think...
Thank you for funding us.
You're welcome. And in fairness to the audience, I think so that they understand, you're a unique individual. You served under the Lingle administration and now in the Abercrombie administration.
Yes.
So these expansions have been going on under both because of what you're suggesting is circumstance. The recession, the Affordable Care Act. Have other states had similar experiences? What's it been like?
I think it differs in other states. I mean, the recession was national. That we saw tremendous growth in Medicaid. Now, the Affordable Care Act had this new expansion,
right?
And that was mandated that every state expand Medicaid eligibility. And that was a decision that actually went to the Supreme Court. And the Supreme Court ruled that it was optional for states.
Okay.
So what you found was many states did not opt to expand Medicaid. Because we had already expanded Medicaid in Hawaii earlier, this expansion didn't cause as great an impact.
Okay.
So I think other states are seeing larger increases in enrollment as a result of their expansion.
Yes.
Because we had already expanded, the growth hasn't been as much as we otherwise would have had.
And are the feds paying their part still for all these programs and these patients?
So for this new expansion group,
yes,
and of that 30,000 increase since October, about 80% of that has been in the new eligibility group authorized under the Affordable Care Act.
Okay.
And the majority of that will be federally funded.
Interesting, interesting. What impact, if any, are you seeing out there in the community, or what are you hearing from hospitals and providers? Are they appreciative of the additional coverage for these individuals that didn't have coverage? Is it a challenge? What are you hearing?
In many respects, I had it much easier than my fellow Medicaid directors, where it really was a political decision about whether or not to expand Medicaid.
Yes.
And in some states, they still haven't decided. So in Hawaii, it was just assumed we would expand and everybody supported it.
Yeah.
So it was much easier for me to know what that policy decision would be.
Right.
And it wasn't controversial. We were able to implement it. I think just because there's a commitment to serve everybody here. There really is a sense of aloha and community. Yeah,
there's no question. I think that at the Capitol, I'll put my Senate hat on, I think it was pretty much, it was an expressed desire from everyone to not just recoup federal dollars. It was really about anybody who needs coverage, because we've come so far from the Affordable Care Act, forgive me, from the Prepaid Health Act in 1974, that we were trying to kind of finish matters off, and we're still there. I think this is a good time to take our first break. We'll come back and we'll talk about innovation at the Medicaid office. You've been a part of CMS. You were the chief medical officer, so I want to hear a little bit about that and how that's informed what you do here. But we'll take a break and then we'll come back to our viewers, okay?
Terrific.
This is Josh Green, Healthcare in Hawaii. Thanks for joining us.
Hi, I'm Donna Blanchard, and I host the show Center Stage on the ThinkTech Hawaii digital series right here every Wednesday from 2 to 3 Hawaii time. I would really love to have you watch the show and see what we do here. I talk with some of the most amazing people, artists, most of them, all of them involved in some sort of artistic process. And our goal here on the show is to dig into that artistic process, and you would not believe what some people say, what some people do, what people go through to express. And these are people who have to express somehow, and I find that infinitely interesting. not only that they have to express, but how they end up doing it. I really hope that you will watch the show and enjoy talking with some of these people the same way that I do. Thanks, and I hope to see you soon on Center Stage on the ThinkTech Hawaii Digital Series, Wednesdays from 2 to 3. See you soon.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island, Chairman of the Health Committee. Today I'm joined by Dr. Kenny Fink. Kenny, as I call him, he's a good friend of mine, who works here at the MedQuest division as its administrator. In our first segment, Kenny was able to describe to us to a degree of what makes up this division, how many patients receive Medicaid in our state, which he said was 310,000 individuals as of June 2014, about 25% of our population. He's worked extensively with the federal government. He's got a great education. He brings a lot of experience, first to the Lingle administration and now to the Abercrombie administration. I have to say he's very well regarded at the Capitol, and especially by me, because I think he understands what it's like to be a doctor and an administrator in our state. But I wanted him to dive into some of the kind of the nitty-gritty, if we could. We've passed the Affordable Care Act. It's now being implemented, but it was a big lift for you. You had to come up with a new eligibility system. Is that right?
That's right.
So how did that work? I mean, you said that we went from 210,000 people back a few years ago, now all the way up to 310,000 people, a huge leap. What did it take to do that, and what are you doing?
Right. So under the Affordable Care Act, there's a requirement that states have a health insurance exchange.
Yes.
Some states could use the federal exchange and some states could have their own.
Right.
Hawaii decided to have its own. So there needed to be an ability to interface between the Medicaid agency system and the insurance exchanges system.
Right.
So our current eligibility system was 25 years old.
Got it.
And it couldn't support the requirements under the Affordable Care Act.
Right.
So we needed a new system. And the federal government recognized most or many state programs are going to need new eligibility systems. They're going to need to modernize.
Are you talking about software or?
Hardware, software, the whole system.
Right.
So the federal government provided 90% federal matching funds.
Okay.
So we needed to implement a new eligibility system.
Right.
A new eligibility system takes 3 to 5 years to implement.
Okay.
We had 9 months to be able to begin accepting new applications.
That's because you're so smart, Kenny. That's
I
why
don't think that's why.
We gave you 9 months.
And even now, we're only a year and a half into it.
Yes.
So there's still a lot of work to be done.
Yeah.
But we worked very hard, prioritized what was that critical functionality to have in place October 1st to begin accepting applications.
Okay.
We were able to go live October 1st. And actually, since October 1st, we have made about 250,000 eligibility determinations.
Wow.
So that includes 70,000 applications for about 100,000 individuals that we've processed.
Okay.
We've also done an additional 150,000 eligibility renewals. So there's been quite a lot of work, and to have done that manually would have been very difficult.
Got it. So just let me take a kind of another half step back here. We have over 300,000 individuals now on Quest, on Medicaid. And because of the Affordable Care Act, you were both putting people who had been in the program still into insurance, and you had all these new individuals.
Yes.
When you say eligibility system, are you talking about someone goes on to it and they say how much they make, where they live, how many children they have? Is that what's in the system?
So we always had the eligibility system that was used to maintain individuals that were eligible.
Right.
So a lot of the calculations would be done by our staff, our eligibility workers.
Right.
But we needed the system to kind of maintain the files and to make sure we made the correct payments to the health plans or process claims.
Right.
But with our new system, we created a new online capability.
Okay.
So people can apply online at mybenefits.hawaii.gov.
We'll get that up on the screen.
And we strongly encourage individuals to apply online. That processing time is much faster.
How fast is it to get processed if you apply?
So for individuals for whom you only need to consider their income and not their assets.
Okay.
So that would be children, pregnant women, families, and kind of your healthy other adults.
Right.
Last month, about 30% of their applications were processed in less than 24 hours.
Wow.
So people who apply online can get next day determinations.
Now, let me ask you this, so that people don't confuse apples and oranges. We heard, I don't want to be mean about it, we heard a few horror stories about people trying to go through the Affordable Care Act, go through the connector, and then get approved. How does this differ from the connector, just so people understand?
In Hawaii today, anyone seeking financial assistance,
Yes.
and that means Medicaid or tax credits through the insurance exchange,
Right.
need to apply to the MedQuest division first.
Okay.
To receive tax credits, you have to be ineligible for Medicaid.
Okay.
So we have a sequential process where we'll determine their Medicaid eligibility. If they're ineligible for Medicaid, we'll send their information to the connector
Okay.
to determine their eligibility for tax credits.
Okay. Does that mean everybody who's trying to get health insurance should start with you, or some people are going to know implicitly, no, I do okay, I'm making enough resources, not necessary, I should just start at the connector?
So both on the connector's website and our website, we have a screening tool.
Okay.
And individuals who are not seeking financial assistance, think they make too much income to be eligible for financial assistance,
Right.
can apply directly to the connector and should go directly to their website.
Okay. And I assume it will kick them, if they happen to not be making enough money, there will be some mechanism to get them back over to you. Is that right?
If they apply directly to the connector, they'll be opting out of financial assistance.
Okay.
So they won't be kicked back. They won't even be looked at to see if they'd be eligible.
So it might be a good, if people have some thought that they might get real serious help through Medicaid. In other words, if like they're watching our show today and they hear, yeah, I'm making less than $13,000 or now $17,000, I guess, right? I ought to apply first to Kenny's program through the new eligibility system, also known as Medicaid.
So today with the process as it is, I would encourage individuals to apply to the MedQuest division first.
Okay.
To ensure that they're not missing an opportunity to get some financial help.
Okay, excellent. Okay, so now you put in this new eligibility system, and you did it fast.
Right.
What problems did you anticipate? What problems arose?
So again, the more that people can apply online, the better.
Right.
We're averaging around 35 to 40% of individuals are applying online.
Okay.
So we certainly want to increase that percentage. When we went live, we had to prioritize some things. So for example, we didn't include long-term care when we initially went live. So that functionality came on later, which was just a little earlier this spring.
Right.
And then we'll need to bring on additional functionality basically at the end of summer. Okay. So we had to phase, and I really credit to our eligibility workers who, it's the duck swimming underwater, may look calm on the surface, but our eligibility workers are working very, very hard, and they certainly deserve recognition. That we really prioritized improving the user experience, but it was largely at the expense of the back-end work that our workers had to do.
Okay. And what does that mean? When you say back-end work, what kind of stuff is that?
So for example, like long-term care.
Okay.
So instead of having the system being able to calculate their earned income and other technical aspects for eligibility, the workers had to manually calculate that.
Okay.
But now the system will be able to calculate that.
Got it. So you're bringing new functions up as we go.
Yes.
For the eligibility system. And flash forward a couple years, what's it going to look like? Is it going to be seamless? Everybody can get determined within 24 or 48 hours because all these new functions come on? Is that the kind of improvements that people should expect from the Affordable Care Act and the work that Hawaii has done?
So the other real change with the Affordable Care Act was the way Medicaid determined eligibility. That for this new adult group, we didn't consider assets.
Okay.
So we used to consider assets for parents and families and for new adults, which are a little more challenging to verify.
Right.
But by eliminating the asset limit, the federal government also created new databases to be able to electronically verify income.
Right.
So we use IRS data, for example, can be used. So the expectation is individuals used to complain, oh, we have to submit all this paperwork. Now we can verify through this federal data hub. And if we're able to verify, we don't need any additional information from the applicant.
So people give their social security number? And
So they can apply online, and we may not need any additional documentation from them if we can verify.
Wow.
And the other wonderful thing is once we go through the cycle and collect tax information for everyone,
Right.
we will then have sufficient information to go verify that we'll be able to resume passive renewal for everybody.
Right.
So once we get into October, no one largely should have to submit any documents to maintain their eligibility. And by verifying through existing data sources, we'll be able to continue their eligibility. So we will have a far greater user experience.
Right.
We'll largely eliminate that churning where people lose eligibility and reapply because they forgot to submit their forms.
Right.
And we'll have improved program integrity.
So it sounds to me, because I know that, and just call a spade, there was a little criticism out there that we had a rough patch, kind of re-upping people. But as you're describing it, there was long-term benefit. To go through this process, we're hoping to have it be more passive in the future because a lot of this, the technical aspects of getting put back onto the program had to be done at least once anyway, and that's what you were doing this past year. Is that right?
We had to comply with the federal law. We had to get tax filing information, which was a new requirement under the Affordable Care Act.
Okay.
So we had not previously, possessed that information or asked for it.
Right.
So we needed to collect that information. We tried a tremendous amount of outreach.
Yeah.
And got a large response, but we wanted everybody who was eligible to stay eligible.
Right.
And a real important point is that if anybody has lost eligibility, reapply.
Okay. That's, I think, a very important, I'm glad you brought that up. That's a very important message for people today. If you've historically been on Medicaid and in the last few months, you received a letter or there was a confusion, just reapply, right? Because you guys are prepared to take those applications, reassess them, make sure people get back into the program. Is that right?
That's right. And if someone goes to the doctor or the emergency room and they have a service and they find out they're not insured anymore,
right,
they can submit an application. And as long as it's within 10 days of that visit,
yes,
we can potentially cover them retroactively.
Good.
So no one who mistakenly lost eligibility should have to pay out of pocket for medical bills. They should reapply, and we can maybe be able to cover their expenses.
Right, and we were pretty clear. We apologize to the people that might have gotten into a rough patch here, but if everything you're saying is correct, which I know it is, we've actually seen a massive increase in the number of individuals that have become eligible, that we're working hard to process and get into these services. And I think that before we take our next break, I think one of the premises that I hold as an important part of healthcare is that we're better off to deliver healthcare when people need it, and we're certainly better off to deliver them comprehensive, quality, preventive healthcare as primary care providers. And you're a board-certified family doc.
Yes.
Me too, going way
yes.
back. So, the point is we want to get people that care. We don't want them to miss out on insurance, even if it has some cost to the taxpayers. We don't want them to end up on dialysis. We don't want them to show up when they have a cancer that's widely spread. We don't want them to suffer and also watch the system suffer because they have very high costs. So we're doing everything we can to get those who qualify into the program.
Yes, we want to get them in, and we want to get them evidence-based care.
Right.
So medically necessary care, it's better for people to get the care that they need through better disease management. This is me, my primary care
yes.
family physician hat.
Right.
We can prevent the complications of disease, which interfere or impact quality of life and also cost more. So we really are trying to keep people healthy and increase the value of basically our program and what we're purchasing.
Okay, I think that's a good place to take our second break. We're going to come back to healthcare in Hawaii in a moment. I'm joined by Dr. Kenny Fink, who's had a vast amount of experience both at the federal level and at the state level running our Medicaid program. Thanks for joining me. I'm Josh Green.
Hello, I'm Martin Despang, and I'm the host together with the one and only Ali Yamashita, and our show is called Urban Transcendence. And Urban Transcendence is about identifying where we have a unique situation of a vibrant city in one of the most beautiful natural environments. So how these two can coincide, sometimes conflict, how they could find reciprocity in the 21st century is what we're excited about. And we're planning on bringing in a diverse body of guests, both from the arts and the science and the established and the wise and the emerging generation. So hope you will join us. We'll always be on Thursdays from 1 to 2 p.m. Thank you.
Aloha, welcome back to Healthcare in Hawaii. I'm Josh Green, Senator from the Big Island, host of this show. Today I'm joined by Dr. Kenny Fink, who's our Medicaid director. He's our administrator, and he's actually an expert on this program, which is a very large program in the state of Hawaii. The Medicaid program, also known as Quest, insures now 310,000 people and rising here in our state.
Yes.
It's got a large budget. The budget, I believe, is over $2 billion. Is that
right?
Is that right? And we're a pretty small state, so that's a big number. But we're really about value, and I think that that's what we're trying to determine here today. We've heard a lot from Dr. Fink. He's told us about the innovations that they had to undertake to make sure the program worked well. They put in a new program that actually helped get people eligible and help sustain that eligibility.
Mm-hmm.
They've really reached out. The program's grown from 210,000 people back in 2008 to 280,000 people in 2013, and then with the passage and the implementation of the Affordable Care Act to now well over 310,000 people, now 25% of our population. So, Kenny, when we spend $2 billion on a program, which is one of the largest expenditures in our state for sure, and we take care of so many individuals, now over 300,000 people, how do we know that the taxpayers get value? And how do we know we deliver good care to people? Could you begin this conversation for us?
So we feel we have a responsibility to serve our beneficiaries.
Mm-hmm.
We are an entitlement program, which means anyone who's eligible will get served.
Right.
But at the same time, we understand that we have a responsibility to be responsible stewards of the taxpayer funds.
Right.
So we're very cognizant in how to improve the value out of our healthcare programs, basically to get the biggest bang for the buck.
Right, because there's a lot of ways to spend healthcare dollars these days.
There are.
And how do you make priorities? You said that you had background in prevention with a major task force for the feds. You have degrees, multiple degrees that focus on, quality care and public health. How do you, as an administrator, decide, yes, we should be investing in prenatal care and immunizations versus surgeries and dialysis or hepatitis treatment? And how do you make those determinations?
Selfishly, but I'm still a practicing family physician.
Right.
And for you as a clinician, still practicing very much.
Yes.
I think having a administrator of the program who understands the clinical aspect, who understands the human component, who understands how care is delivered, what providers experience, that interaction with patients is very valuable to the decision-making process. I also think that my background in evidence-based practice, I spend quite an amount of time reviewing the literature, staying current with the literature, that when we're looking to do new things, to make a decision, say, well, what do we scientifically know about it? If you're going to spend your money, you want to make sure you're spending on something that works.
Right.
So we try to be very judicious about that.
And money, I think that people need to recognize, the Hawaii has one of the most progressive programs probably in the whole country. And when I say that, I mean, by a percentage, we probably provide Medicaid to more people by a percentage than most other states. Is that fair to say?
It's on the higher end.
Okay.
It's not an outlier, but it's on the higher end.
Okay, so we're committed to this program,
Yes.
but to be candid, healthcare is expensive, and budgets can be finite. So how do you decide? How do you decide we're going to take care of the whole large piece of this population that need it, that have obvious and evidence need, without going over? And I mean, what happens if you go over the budget? And we've added more people I know we've increased the budget somewhat. What happens if at the end of the year we're $300 million over? What would happen?
So I'm pleased to say, I think it was since my first year, we've stayed within budget.
Okay.
So for every year other than my first, we've stayed within budget. If we went over budget, we would need to presumably go in for an emergency appropriation from the legislature.
Right.
And things can happen that are unexpected. You can have an unexpected change in the economy or something that all of a sudden, there's a huge demand. But I again recognize my staff. We've budgeted well and have managed our program tightly, and I think that has helped. But I fully recognize it's not about the bottom line all the time.
Right.
And often in healthcare, you need to spend money to save money. So by spending more money and getting quality of care, recommended services, that may cost more now, but that will save money in the future. So, oftentimes we talk about this term cost-effective.
Right.
And cost-effective doesn't mean cheapest.
Right.
It means it's the greatest impact on outcomes for the amount spent. So if you can spend a whole lot of money in these recommended evidence-based services, disease management, that will serve you well.
So you're talking about managing, say, a large number of people, for instance, with diabetes. We've talked about diabetes many times on this show. Or maybe you find a good way to spend money on exercise programs for people who have morbid obesity. You might spend money, but then not have the ultimate outcome where they need cardiac surgery or surgery for their, for infections that cause sick limbs or all these things. Now, how do you convince people, though, to spend money for something that's several years down the road?
I try to go to the legislature and convince legislators to fund those initiatives. So, some of the things we do is we measure our quality, and we've done a number of things to improve the value of healthcare. We are now almost entirely managed care, so it's the requirements we have of our health plans. So we have basically pay for performance with our health plans. We identify certain areas that we want them to focus on, and if they achieve certain goals, we'll pay them some extra money. One of the conditions I'll just have in front of me was blood pressure control. Blood pressure control leads to heart attack and stroke. It's the silent killer, as you know, also causes kidney disease and failure. So between 2009 and 2013, of those with diagnosed high blood pressure, in 2009, only 30% had it under control. In 2013, over 50% had it under control. That's a pretty substantial increase. And when you look at the population, and this also includes the growth of our beneficiaries, that's a tremendous public health impact. So if we can reduce a couple of heart attacks and strokes, I mean, that was money very well spent. And it also improves our quality of lives, live longer, feeling better.
Yeah, the clinicians in us know that it's nice that someone didn't have to go through the heart attack, didn't have to go through the stroke, which is catastrophic for a family and an individual. But the interesting part is I think it comes at an interesting time when we're also aging as a population. So we have an extra burden of some disease, just because it's natural for people as they get older to have some of these illnesses. Certainly a lot of the cancers come, much later in life. And I know that cancer prevention and cancer screening has also been a focus of the programs you've described. And when you say the plans, you're talking about HMSA, Aloha Care, United, HMAA, is that right?
So Medicaid is the broad umbrella of the program. Within that, of the insurance program, we've had two delivery programs. One was Quest, and the other is Quest Expanded Access. So those are the programs by which we use to deliver services, but they're both under the umbrella of Medicaid. So we will be doing some innovative work around those programs. But when we talk about the aging population and really the role of Medicaid in long-term care, I'd also like to talk about it benefits seniors to be able to age in place. They want to stay at home and in the community. They don't want to end up in a nursing facility unless they have to. So we have invested tremendous effort to what we call rebalanced long-term care, where of folks receiving long-term care, previously only about 40% were receiving care at their home or their community. Now that's over 65%. So we continue to increase access to home and community-based services. Again, the seniors like it because they can stay at home and in the community and a better quality of life. It's also less expensive. One of the innovative things we're working on is expanding access further to home and community-based services. So instead of needing services for meeting this institutional level of care, we're going to expand services to people who are at risk of deteriorating to level of care. So again, this is more on the prevention side, where we're going to invest more money, expand access to more services in the hopes of keeping people in the community.
And how do you find out who those people are? What's the process?
Our health plans will go do assessments of folks. So every new applicant will get a phone call or a flyer to assess if they have any special healthcare needs. If they do, the health plans will do a face-to-face assessment.
Okay, and then they can begin to stratify risk about someone who's going to run into big trouble, which can mean big trouble for them, big trouble for the state because it could be very expensive, big trouble for the plan, and ultimately, if people think that that's too mercenary an approach, I would remind everyone that we want to keep a large number of people getting these services if they're eligible for them. If we don't innovate in some way, which I really appreciate hearing from you how you're doing it, we wouldn't be able to take care of the 300,000 plus individuals. The number would be much lower. Is that correct?
Yes. By expanding these home and community-based services, we've decreased the pressure on the nursing facilities. There are more beds, which makes it easier for people to get discharged from the hospital into the nursing facilities. So the whole system benefits.
Okay, yeah, it seems like the system depends on multiple layers of this care. And have you had good cooperation from all of the plans? What's it been like?
Very much so. Right now, this is occurring in our Quest Expanded Access program.
Right.
So they've already been familiar with this process. They'll be using our current assessment tool. So we continue to increase the number of folks that we're serving.
And you said something to me earlier as we were talking. You said that there's going to be a Quest integration movement going forward. Tell me a little bit about that before our next and final break.
We've probably been working for 2 years on this idea of combining Quest and Quest Expanded Access into a single program, which we're calling Quest Integration. What we experienced is that if someone were in Quest and they became disabled or turned 65, they might have to go to a new health plan, might have to change healthcare provider. It was very disruptive around a particularly vulnerable transition phase. There are also families who might have had certain family members in Quest and other family members in QXA. It just wasn't patient-centric.
Okay.
So we thought that we could do better. So we developed this Quest integration program largely in response to the community and their suggestions and feedback that we had received. And not only will it improve the transitions of care, it will also improve choice. So currently for individuals who are what we call aged, blind, or disabled, they can choose among 2 health plans. Now they'll be able to choose among 5 health plans. So Quest integration is going to begin January 1st, 2015. There will be 5 health plans.
Great.
Aloha Care, HMSA, Kaiser, Ohana, and United Healthcare.
Great. And what will that mean to the average person who's on Medicaid? Who will have to make that determination of a change?
We will have an open enrollment in September, and we'll be doing public outreach and mailings prior to that. So people can expect to be hearing from us. That will be an opportunity for individuals who want to change health plan to choose a different health plan. For individuals who want to stay with the health plan they don't have to do anything, and they'll stay with their same health plan.
Okay.
If they do choose a different health plan, that will take effect January 1st, 2015, when everyone will be in their new health plan.
Right.
And then we mentioned some of the other things we're doing new, which are, for example, these at-risk services, which will be available from all the health plans beginning in January.
Okay. Well, I think this is a good place to take our final break, and then we'll come back and talk about your vision for healthcare going forward.
Outstanding.
All right. So I'm Josh Green, your host, Healthcare in Hawaii, joined by Dr. Kenny Fink, who's the administrator at the Medicaid division here in our state. Thanks for joining us.
Okay, this is ThinkTech, and one of our favorite shows is Hawaii, the State of Clean Energy. And it goes 4 to 5 every Wednesday right here from ThinkTech in Pioneer Plaza at the core of downtown Honolulu. And my co-host is Ray Starling from Hawaii Energy. Ray, do you like the show?
I love the show. It's great to see all the new people coming in with new ideas about how to save energy, get us off of fossil fuel, and that's what it's all about. So Hawaii, the State of Clean Energy. See us on Wednesday afternoons at 4 o'clock.
I knew he'd say that. Thanks, Ray.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, physician from the Big Island, senator from the same. Today I'm joined by Dr. Kenny Fink, who really runs the Medicaid division as its administrator, has explained to us how large a program and important a program it is. And that's my words, because it is very important. It's 310,000 people who get health care insurance here in our state because they have some challenges economically. I wanted to spend these last couple of minutes with Dr. Fink, with Kenny, just asking him what his vision for healthcare is going forward. He's had incredible latitude of experiences. He's been with the federal government. He's been here now for many years, over 6 years with us, working with both the Lincoln administration and the Abercrombie administration. He's seen an increase from 210,000 to 310,000 individuals in this program, and he really understands healthcare because he's also a family doc. So for a couple minutes, Kenny, tell us what your vision of healthcare is going forward and what we might expect or what we maybe should do.
So I think within healthcare, looking at healthcare financing and then the organization and delivery of care.
Yes.
And then ultimately is how do we make that as smooth as possible to minimize intervention in the doctor-patient interaction, because really that's what this is about, or the healthcare provider-patient interaction and delivery of care.
Right.
Between Medicaid, public employees, retirees, the state is purchasing healthcare. By state, I mean the state government, for 40 to 50% of the state population. Mm-hmm. I think there is an opportunity to leverage the state's purchasing power and to use that to streamline how healthcare is purchased with tremendous administrative simplification.
Got it.
So you can look at other states that have healthcare authorities where they've aligned basically the Medicaid program, public employees within one state organization. I think sometimes they're insurance exchanges as well now.
Right.
So that is one way to get that contractual alignment, one fee schedule, to really make it simple for providers, make it easier.
And I think that that's important that you mentioned that. I'm so pleased you did, because just to remind people, we have, like we've said today, over 300,000 people on Medicaid, and we have a very large population of civil service workers, union workers. I believe the number is around 150,000 maybe individuals, and some of their dependents.
Yes.
So now you're talking about virtually half of the state, like you say, but there's still multiple programs and multiple choices. And when it comes back to the doctor or the hospital, lots of administrative costs, lots of challenges and complexities. Some hospitals went under when they couldn't manage it. Other physicians have kind of thrown their hands up and said, I'm just going to take the high-paying insurance plans. And what you're saying is, by streamlining this, we can get the providers on board, make a better healthcare system, and ultimately get everyone healthcare. Is that what you're speaking of?
I think there's some opportunity there.
Okay.
From the delivery of care, Hawaii relies quite a bit on the solo provider, small practices.
Right.
Very difficult on those providers to do that. And to think of where to go, and my belief is we have to move healthcare out of the exam room. So how do we manage populations? How do we use electronic health records and other communication with patients to manage that care outside of the exam room? So you're only seeing the folks that really need to be seen. So routine disease management, routine preventive care doesn't have to occur in a face-to-face visit, but the providers need the support.
Right.
So by having large group practices, the independent physician associations, but what are those provider-led organizations that can provide that support with those economies to do care management, to do registry management. But I think if we can move toward that, to creating that infrastructure, to the first step of doing that population-based care, then you can really let the providers focus on those higher acuity patients and those quote-unquote super utilizers and put them in more intensive care. So I think there's a number of opportunities both on the financing side and on the healthcare delivery side, but they both need to occur concurrently.
And I think what you're saying reflects what's come up before, that because of the shortage, we've talked about the shortage on this show a few times of providers. Hawaii, I'll remind people, we're 22% short of physicians. That's our best guess from the work that's been done at JAPS and with Kelly Withy. We have to have providers practicing at the top of their license, at the top capacity that they can, especially because many individuals who are sick, that piece of the population consume most of the resource, and that's where we have to give people the help.
Yep.
We're about at the end of our program today, but I wanted to say thank you, Kenny, for joining me.
Thank you,
You
Senator.
provide an excellent perspective. This was Healthcare in Hawaii. I'm your host, Josh Green. In the coming weeks, we'll continue our conversation about healthcare reform in our state, about what the state can do to make your life better, from a health perspective. It's always a big challenge, but it's one of the most important topics, and that's why we're here. Thanks again, Dr. Fink.
Thanks, sir.
You bet.